Good afternoon, and thank you for giving me the opportunity to talk about motivational stages and appropriate intervention. These are the objectives. First of all, let me declare that I have no conflict of interest. Um, so we will try to try to understand the stages of change model, identify clients' characteristics at each stage, apply appropriate motivational interventions, and to understand what are the evidence-based approaches to enhance motivation in each stage and address relapse. We'll talk about this very briefly. Let's discuss about the behavioral changes. There are multiple models of changes which have been proposed to explain the behavioral changes. It ranges from the classical and operant conditioning, which is based on learned association, reward punishments, and according to this theory, the behavior is shaped by external stimuli. But those are too much focused on the external environment, ignoring the cognitive and emotional factors. Subsequently, the health belief model, which stresses upon the perceived susceptibility, perceived severity, and perceived benefit versus barriers and cues to actions, but they are silent about how do changes happen in life. Thereafter, the theory of reasoned action and its extension, theory of planned behavior, those concentrate on the attitude, subjective norms, and perceived behavioral control, but ignores emotional and habitual aspects of behavioral change. All these previously proposed models are either too rigid or linear or incomplete. And Prochaska and DiClemente has, during their study on smokers, they theorized that change process is a journey through various stages, and people usually think about behavioral change, initiate behavioral change, and maintain new behavior rather than making an instant change. So they have proposed the holistic model. So this integrates the cognitive aspects and other stages. So there, it describes how people move through stages while making the behavior change. So there is a transition from pre-contemplation to contemplation, preparation, action, and maintenance. And these stages of change helps tailor intervention to meet clients' need at their level of readiness. Each of these stage, in each of the stage, clients have different levels of their readiness, and we can tailor-make interventions. So in pre-contemplation, usually the clients are not considering change. Sometimes they are unwilling or discouraged, and often they minimize the impact of their substance use. So they are many of them are focused on the good experience of the substance. Some are rebellious, being afraid of losing control of their lives in terms of substance use. Some are unaware about harmful effects of substance. Some others are hopeless, helpless, and overwhelmed due to substance, and a few rationalizes the behavior. Next. So here the counselor's job is to build rapport and trust, and at the same time raise doubt and concern about the substance use, to assess the stage of change and readiness to change, and to address motivational issues for clients, especially those who are mandated for treatment. Now, the counseling strategies, first of all, the engaging is a difficult task in pre-contemplation stage. The clients need to be commended for coming to the treatment. At the same time, the counselor should express concern and keep the communication open. And if possible, the focusing and evoking tasks can be considered once the patient is engaged. For that, to elicit clients' perception of problem, explore the events leading to treatment, and to provide the information on risk and personalized feedback, and involve significant others for supporting the patient, of course, with the permission of the client, can be considered. Now let's come to contemplation stage. The individual recognizes a problem and begin considering the changes, but at the same time they experience ambivalence, and that is seeing both reasons to change and reasons not to. And substance use continues, but the client contemplate reducing or stopping, and in this stage they may start seeking information, re-evaluate behavior, or consider help. So this is a stage where we can engage in decisional balance, and but we must understand that the client may remain in this stage for an extended period, fluctuating between readiness and hesitation, and that is an usual thing. So in the contemplation phase, the counselor needs to focus on normalizing as well as resolving ambivalence, and if possible, to help tip the decisional balance scale, to support exploration of choice and option, and to emphasize personal choice and responsibility, which is a core part of MI. So the counseling strategy here, the counselor may concentrate on shifting the focus from extrinsic to intrinsic motivation. We'll see it in further details in next slides, and to reintroduce the feedback and explore self-efficacy, summarize the client's concern. So as a whole, to focus on the issues, and evocation, if possible, to assess the decisional balance, exploring the pros and cons, to summarize change talks, etc. Now, many cases we find in our OPD or in substance use disorder treatment clinic who are mandated for treatment, means they are coerced or forced by some external agency to seek treatment. There, the inherent difficulties are strong emotion, fear of adverse consequences if they are non-adherent to treatment, and at the same time they are poorly unaware regarding their substance-related issues. So these cases may even require the decontamination of referral, that is, honoring the client's emotion. At the same time, the negative emotions needs to be addressed, and to establish and inform what information will be shared with the referring agency. And at the same time, the patients need to be provided unconditional support by acknowledging ambivalence, and the therapist role needs to be differentiated from that of the authority. And at the same time, the counselor should try to remain detached from taking sides of both the patient as well as the referring authority. And we must not assume what type of treatment is needed for these cases, because it needs to be tailor-made. And here comes the role of intrinsic motivation as well as extrinsic motivation. Those who are mandated for treatment, they are mainly initially the source of motivation is extrinsic. It might be the spouse, employer, doctor, family, etc., which may press the client into treatment and can make them stay in the treatment. But for a long-lasting changes, the intrinsic motivation which comes from the patient is needed, and interestingly, it can be improved by intervention. We can start by asking simple questions, that where are they and where do they want to be? What is their goal? And genuine curiosity regarding substance use and its effect may gradually evoke those responses which may draw the client towards intrinsic motivation. Here comes the tipping of the decisional balance. It can be done by exploring the good and not so good things regarding substance use, and we should understand that decision to stop substance use might be associated with a sense of loss and grief because it was the part of the repertoire of the patient, and as a result it is commonly associated with reservation about the change. So it the counselor should maintain pace with the patient rather than engaging into the premature decision making. And as a result, the relative strength of each of the motivational factors need to be weighed, highlighting the weight client placed on each of the change factors to explore both sides of the ambivalence and to summarize the findings. A good summary involves in collecting the positive aspects of clients' change talk and presenting them back to them in a consolidated, meaningful manner, highlighting their own reason to change and reinforcing their motivation. So, these pre-contemplation and at the end of pre-contemplation and contemplation, possibly we would get the done change talks, that is desirability, reason, and need. And at the hilltop of MI, at the end of the contemplation stage, where the patient is going to the preparation stage, we can ask the key questions. That is, what do you think you will do about your substance use? After reviewing the situation, what is the next step? Where do you go from here? And these may evoke the CAT change talks, that is commitment, activation, and taking steps. So when the patient lands into preparation stage, probably the decision balance has been shifted. The patient perceives benefit of change, and individual relatively strong commitment to change. They begin planning specific steps. Self-efficacy is assessed. Substance use continue, but the individual intends to quit soon, and small changes begin with setting goals and share their commitment. So here we should understand that setting goals is a joint process. The therapist should facilitate the client to identify and clarify treatment goals. The clients identify preferred change goals and enhance their commitment. Now, it can happen that the client's preferred treatment goal may not match that of the therapists. In that case, the role of therapist is to negotiate, to figure out how to work out with the differences, to roll with the resistance kind of thing, to approximate, to try to find an agreed upon goal which is similar. But if that is not possible, may even consider referral to some other service providers. That's why it is not like guiding someone, it is like a dance. You may take two steps ahead, one step backward, like that. So for preparation, the two key tasks is to explore goals and to develop plans. For exploring goals, the counselor needs to clarify clients' goals by using open-ended questions to encourage goal sampling and experimentation and to elicit change strategies from the patient. Whereas to develop plan with permission of the client, the counselor can offer menu of change option, negotiate a behavioral contract, identify and lower barriers to action, and enlist social support. So to develop a plan or to incorporating other strategies, a behavioral contract may be considered, which is a jointly agreed upon, might be written contract. That is part of a go-public rituals, and that may be part of contingency management, where the behavioral contract is agreed upon, and based on that, based on sticking to that contract, contingency management is applied to identify and lower barriers to action, to discuss with the client about potential barriers to treatment program, and for this information may be provided to the client with permission, and active referral and social support, which is an important thing to encourage client to keep social support strategies, to engage in social activities without substance use, resuming connection with supporting family members, and it may extend to participation in 12-step facilitation or addiction focused recovery groups. For action stage, the individuals select change strategy, they engage in modifying substance use behavior, lifestyle changes are made to support recovery, may encounter various challenges during this action phase, such as temptation like craving or withdrawal. And at the same time, they begin to redefine their self in identity, and those who are in action stage show commitment to change and follow recommended strategy. So what would be our the counselor strategies? So the counselor focus on support and evaluate the progress, that is what is working and what isn't, what else may work, and what is the next step, to identify which strategies work and to adjust as needed to modify ineffective strategies. So those who are maintaining, the focus is on sustained progress, preventing the recurrence of substance use is a priority. Individuals take extra precautions to avoid reverting to old behavior, learn to identify trigger, develop some coping skills, and work on building new lifestyles without substance use. So here also the counselor focuses on stabilize change and support lifestyle adjustment, and counseling strategies are to engage and retain in the treatment, stabilize change and support lifestyle adjustment, to develop a coping plan, identify new behaviors, reinforcing changes, strengthening family and social support. So what can be the barriers to recovery and how to handle them? Uh, First, during this maintenance phase, there is premature treatment discontinuation. For that, client's emotion, goal, comorbidity, and substance use disorder severity needs to be explored. A strong therapeutic alliance should be built up and to explore and resolve treatment barriers. Those who are lacking self-efficacy, often they'll end up into lapses and relapses. For them, high-risk situation exploration, coping strategies, and exploring clients' idea and confidence regarding these high-risk situations needs to be explored and to handle. Uh, and last but not the least is the void after abstaining from substance. So, as we have discussed earlier, also the substance use in those who are dependent to substance is part of their repertoire, and that is part of the salience. So, once it is stopped, we need to identify new behavior to fill the void. That might be the voluntary work, 12-step facilitation membership, spiritual and cultural activities, but we must understand that these two needs to be jointly agreed upon. Here comes the role of recovery capital, which are the external and internal resources, including the coping strategies, social support, etc., to facilitate the recovery. And at the same time, we need to reinforce family and social support. Once we deal with these barriers, we can aim for a meaningful recovery. And no discussion of stages of change is complete without discussing about the relapse. So there are various high risk situations, antecedents like lifestyle imbalance, immediate urges and cravings, need for immediate gratification, as well as cognitive distortion, which acts as high risk situation. And once those are effectively dealt with, there is enhancement of self-efficacy and reduction of relapse risk. But once there is ineffective coping and poor self-efficacy, it may lead to lapse. The relapse management in lapse stage may improve the coping strategy, but if the relapse management is not done promptly, it may lead to abstinence violation effect, which may increase the relapse risk. So the counselor needs to be cautious about chance of relapse, and they need to communicate with the patient regarding these kind of possibilities. So to conclude, the stages of change refers to dynamic process involving progress through a series of change. It helps tailor intervention to meet clients' need at their level of readiness. Pre-contemplation and contemplation warrants rapport building, engaging, followed by focusing and evocation to tip decision balance to the change. Preparation stage of motivation allows to formulate plans and setting goals. Patients in action stage select change strategies and engage in modifying substance use behavior. Preparing for and preventing relapse must be incorporated in the management plan. The therapist should always be vigilant about the risk of relapse and barriers to recovery and use the available resources to mitigate them. Thank you.